Hi all, good afternoon. Ma'am, are you audible? Yeah. So, first of all, I would like to welcome you all for the session, and ma'am, Padmasri ma'am, a very warm welcome for you, and thank you to be with us. And so we have only two more sessions to go. Thank you, participants. And I'm handing over to Anusha ma'am to introduce our faculty. Ma'am, over to you.
Good morning, everyone. This is Anusha. I'm the facilitator for today's program. So today our topic is geriatric care. Our speaker, Dr. Padmasri Nair Garu. She is working as Amrita Institute of Medical Sciences at Kochi and Department of Geriatric at Amrita Institute of Medical Sciences. And her academic qualifications, MD in Geriatric and at Karnataka, and she did MBBS in Amrita Institute of Medical Sciences only in Kerala, and research contributions, video histogram, video histomographic findings in vascular Parkinsonism, and a diagnostic and prognostic value, and clinical features and cognitive impairment in vascular Parkinsonism, and an observational study, and areas of interest in geriatric medicine, neurodegenerative disorders and cognitive impairment, Parkinsonism and healthy aging, and professional strengths. She is committed to enhancing the quality of life for elderly patients through evidence-based practice, clinical research, and holistic management. Thank you, ma'am. Welcome for this session.
Thank you so much. Shall I start the presentation, and do we have any more participants we're waiting for?
No, ma'am, we can start. Actually, they will join. Ma'am.
Okay.
Okay.
All right. So is my screen visible?
Yes, ma'am.
Sorry, is it visible?
Yes, yes.
Okay, all right. Good afternoon to all the participants. So we are going to talk about geriatric care today. So, what is happening? Actually, what screen is visible right now? Is it my
Agenda is visible. Ma'am. Introduction to geriatric.
Yeah, just a second. Yeah. So, these are the topics that we're planning to cover today. One is the introduction to geriatrics. Then we're going to talk about the 5M framework in geriatrics and how to assess geriatric patients. And the last part we'll be discussing about is the role of nurses in geriatric assessments. So, before I introduce geriatrics, I'd like to put forth a case to all of you. So, we have a patient named Mr. X. He's 89 years old and he lives in a nursing home for the past 2 years. So, on presentation, his complaints were worsening shortness of breath, which he previously had, along with increasing fatigue and reduced oral intake. And all of these symptoms have been there since the past 2 weeks. So, a little into the history. So, he's been having progressive breathlessness at rest. He's also been having orthopnea, that is, difficulty in breathing when he's lying down flat. And he's also had reduced mobility. Apart from that, he's had fatigue and increased sleeping during the daytime hours. He's had difficulty in swallowing solids as well as poor appetite. And in the nursing home, he was receiving physiotherapy. But at this point, he decided to refuse physiotherapy, and he said that he was tired of it all. Now, his daughter reports that there is emotional withdrawal and discussions about being ready to go. That is, he has accepted about his uh, the approaching end of his life. Now, coming to the past medical history, he already has been diagnosed with advanced congestive heart failure. He has COPD. He has chronic kidney disease. He has type 2 diabetes. He has vascular dementia, BPH, that is benign prostatic hyperplasia, and history of stroke about 5 years ago. Now, if you look on the right side, we have the medications that he's been taking. So he's on furosemide, which is a diuretic, and he's taking a dose of 80 milligrams, and he's taking it twice a day. He's on metoprolol, 50 mg twice a day. He's taking lisinopril, an antihypertensive, at a dose of 10 mg, and he's taking it once a day. Spironolactone, again another diuretic, 25 mg, and he's taking it once a day. He's taking a tiotropium inhaler for his breathlessness. He's taking a salbutamol inhaler for his breathlessness. He's taking insulin, glargine, which is a type of insulin, and he's taking 30 units at night. Again, he's taking metformin for his sugars, 500 mg, and he's taking it twice a day. He's taking atorvastatin, 20 mg, for cholesterols, and he's taking that at night. Apart from that, he's using finasteride, which helps with his prostate. He's taking a dose of 5 mg, and he's taking it at night. He uses donepezil, which is for his dementia. He takes it once a day. And he uses lactulose, which is a laxative for easy passage of stools. Coming to his social history, he's a widower. He's a retired mechanic. So in this situation, his daughter is the primary decision maker. She has a power of attorney. And another part of his life is that he is no longer ambulatory and he is wheelchair bound. And he has also expressed his preference to not be hospitalized again hereafter in case of any further worsening. So when we come to geriatrics, this is how we approach our patient. First thing is we review his medications, and we feel that the steps that we've done with his medication review is to stop the metformin. We've stopped the statin as well as the donepezil. Now, all of these drugs are found to have moderate evidence when it comes to management of conditions at a late stage. So, with regards to his kidney disease, metformin is not the best drug to give. So, we've stopped that. Statins and donepezil at this age, 89 years, may not help him as much as we expected to. So, we've stopped both of those. We've adjusted his doses of diuretics and insulin because he's not taking enough orally. We've reduced the dose of insulin so that he doesn't have hypoglycemia. And diuretics, again, it becomes a distressing symptom if he has to go to the washroom recurrently because of taking a diuretic. So we've reduced the doses of that as well. Now, since he's already talking about his approaching end, we also have to ensure that we give adequate end-of-life care. So we've decided to respect his decision. We've avoided hospitalization. We've included a palliative care team for further management of his symptoms. We've taken a DNI, which is a do not intubate consent, with which we created an advance directive in order to ensure that the patient does not get intubated if at all he worsens further. And additionally, we've also given him adequate counseling to address his emotional as well as his spiritual needs. Now, coming to symptom management, for his breathlessness, which has worsened recently, we decided to introduce low dose of opioids. We started him on oxygen therapy. Now, for a patient who was mobilizing previously on a wheelchair, now when he's become bedbound, we've initiated pressure sore prophylaxis, and we've also ensured that he has adequate bowel care. That is to ensure that he's passing stools regularly and that the cleaning of all the private areas also are done properly in order to avoid any infections in the local areas. Now, coming to supportive care, we've improved his nutritional quality. We switched over to RT feeds since he's been complaining of difficulty in swallowing. We've changed over to a rice tube feeding, changed it to soft feeds, and we've increased his protein intake as well. And we've also ensured that he's taking adequate amount of fluids. So now coming to what is geriatrics? So it's a specialty that is focused on high quality person-centered care for the elderly. Usually we see patients above the age of 60. Now, when we talk about high quality care, it aims to improve the health and not just that, the independence and the quality of the life of the elderly people. And when we talk about person-centered care, it puts the personal values and preferences of these elderly over our general guideline-based practices. So with this, we come to the 5M framework of the uh, field of geriatrics. So what this framework does is it helps us to make decisions for each patient based on the 5Ms. So when we talk about the 5Ms, we have one, which is multi-complexity. Second is the state of mind. Third is the medications that he or she is on. Fourth is the mobility of the patient. And fifth is what matters to the patient. So coming to multi-complexity. So in the case of geriatrics, we aim to look at a patient as a whole. So we often see all of their symptoms or their complaints as an interaction that happens between the presence of their chronic medical conditions, the presence of advanced illnesses, and the psychosocial needs that come because of these illnesses. So when all of these interact, that is when patients come with complaints. And so when it comes to treating these patients, all of these three things have to be addressed in order to get a good response for these patients as well. Now, coming to the mind, whenever we see a patient, we assess their mentation, that is their state of mind. So we treat what is known as delirium. Delirium is an acute change in the state of mind. Usually, it happens when there are any electrolyte imbalances. Say if there is low sodium, they start behaving differently. They may not recognize people. They may become drowsy. So that is one presentation of delirium. It can be due to acute infections. It can also be if they're severely dehydrated or if they're in severe pain as well. Now, another thing that comes with aging is depression. So mostly what happens is that the changes that come with aging may not settle well with elderly, especially those who have mobility issues, may be very unhappy with their current functional status. And that causes a lot of depression among these people. They may be living away from their children, or they may have lost their spouse or their friends recently. So, all of these could contribute to depression. In that case, it needs to be addressed in order to ensure their quality of life. The next thing that we look at is whether the patient may or may not have dementia. Now, dementia is a progressive condition where there is cognitive decline. So, it is important that each time we see the patient, we assess them to see if there is a progressive decline in their mental function. Coming to medications, now, one term I'd like to introduce here is polypharmacy. So, if a patient is on more than 5 drugs on OPD basis or more than 9 drugs on IP basis, we call it as polypharmacy. And usually, when we approach any elderly patient, most often they do end up having polypharmacy. And our main step here is to review their medications and start de-prescribing. That is, stop unnecessary medications. And also, another thing that we need to focus on is optimal prescribing. That is to ensure that the quality rather than the quantity of medications that serves the needs as the patient ages. Then again, it is important to monitor any adverse drug events, that is, any kind of reactions that a person can have to medications, and that needs to be noted properly. Along with that, we need to follow up the drug compliance, that is, whether they're taking drugs regularly as we've prescribed or if they're skipping out on it, because then you may not get the desired results. And again, another thing to be introduced in elderly is the prescription cascade. So this is an example of a prescription cascade where a doctor has started a patient on amlodipine for hypertension because his BP was high. Now, one of the side effects that we get with amlodipine is ankle edema, that is swelling around the ankles. Now, when the patient is presented with swelling in the ankles, the doctor decided to start him on furosemide. Now, this is a diuretic that causes increased passage of urine, and that has resulted in increased urinary frequency. Now, when the patient presented with urinary frequency, the doctor started him on tamsulosin, which is a drug that is used for BPH. Now, another problem that has come with these medications is that the patient has developed hypokalemia. Now, now this happens because of the diuretic that causes potassium loss in urine. And another thing, again, furosemide, which is a diuretic, also causes dehydration, because of which the person has started developing dizziness and low BP. Now, because of this, the patient ended up getting admitted in the hospital. Now, this shows why multiple prescriptions can lead to several interactions. Now, when the patient had come back with ankle edema, if the doctor had reviewed his medications, they would have been able to pick up that the drug causing all of this was amlodipine. So the only thing that had to be done here was to change the amlodipine to another antihypertensive. But in this case, unfortunately, the patient was prescribed on multiple drugs, all of which have resulted in worsening of the patient's condition and further hospital admission. So this is what is known as a prescription cascade. Now, coming to mobility, again, when a patient presents to us, we often assess their mobility. Now, two things that we do is ensure that they have safe movement and that they are able to maintain function and do what matters to them. And the second thing that needs to be done is fall prevention. That is, if they have risk for falls, when we assess their mobility, we need to also recommend changes or modifications in order to prevent them from falling. And along with that, our measures should also include recommendations that prevent injuries from falls as well. So we often do suggest changes in their environment and whether they should use walking aids or anything of the sort to prevent either falls or the injuries that can come from falls. Now, the next M that we're going to talk about is what matters. So, again, as I mentioned earlier, for patient X, he had already made it clear that he did not want to be admitted further in any hospital. And keeping that in mind is how we develop a care plan for the patient. So, again, what matters here means that we should know what our patients want, and our care plan should align with what they wish to have in their life. And again, the specific health outcomes or the goals that we set also come in line with what they want from visiting our OPD. Now, coming to the assessment of elderly. So, there are two ways to go about it. One is the clinical assessment, which is what we do by clinical examination. The other we have is the toolkit based assessment. Now, this involves the basic assessment, which includes physical, cognitive, psychosocial, and nutritional assessments of patients. Now, two of the most common screening tools we use is the ICOB screening and the comprehensive geriatric assessment. Now, both of these can be administered by nurses as well, provided they've got adequate training on how to administer these to patients. So, coming to the ICOB screening. Now, ICOB screening mainly looks into these domains. One is cognitive decline. It looks into limited mobility or immobility, malnutrition, visual impairment, hearing loss, and depressive symptoms. So for cognitive decline, the most common test that we do is a 3-word report. So if you look to the second column, we can see the tests have been described here. We ask them to pay attention while should I
You can
stop or
continue,
should I
ma'am.
continue?
Yeah.
Okay, sure. Yeah. So in cognitive decline, we ask the patient to repeat the tests that we give. And first is an immediate recall where we ask them to repeat the 3 words. And thereafter, we ask them to keep it in mind, to remember it and keep it in mind because we will ask them later. Following that, we ask them the question that revolves around their orientation to time and space. So usually what we ask them is what is the date today and where are you sitting right now? So is it in the home or is it in the clinic? And once they finish answering these questions, we ask them to recall the 3 words that we told them earlier. Now, if there is any impairment, that is either they are not able to recall the 3 words, or if they're not sure about their orientation, then the patient requires detailed assessment. When it comes to mobility, we do the chair rise test. That is, we ask them to rise from a chair with hands, like with the handles. They can use, and we have to tell them that they are not supposed to hold the handle and they have to get up 5 times and sit down again. And we time the and we time them. Now, if they take more than 14 seconds, that indicates that the patient has declined mobility. When it comes to malnutrition, there are different ways to do it. The most common screening that we do is we ask them if they've had any unintentional weight loss. That is not because they went on a diet or because they've been recently working out, but have they lost weight without trying? And we usually keep the cutoff as more than 3 kgs in the last 3 months. The next thing we ask is whether they have decreased appetite over the same amount of time. The next is that we assess is visual impairment. The one way to go about it is to ask them if they have any difficulty reading a newspaper or watching TV. The other way is to do a Snellen's chart. That is your normal visual testing. Now, for hearing loss, we do have tests like audiometry where we can refer the patient and get an audiometric analysis done. Or the most common screening test that we do is a whisper test. Now, I'll be coming to it as in the further slides. The next thing that we talk about is depressive symptoms. So again, for screening, we ask them 2 questions. That is, have you been feeling down, depressed, or hopeless over the past 1 or 2 weeks? And we also ask whether they've lost interest in their hobbies or they do not feel happy doing things that they used to enjoy before. So coming to the cognitive assessment in ICO, now there are different, all of these are toolkit-based tests. So the most commonly used one is Minicog. Now Minicog again has 2 parts. One is the 3-word recall. That is, you give them 3 words and you ask them to recall those words later. And it also involves a clock drawing test. But again, the drawback of this is that it cannot be given or it cannot be administered to those who are illiterate because they may not be able to draw a clock or mark the time properly. Now, the next test we have is the Montreal Cognitive Assessment and the Mini Mental State Examination. Now, both of these are more or less similar, but in India, we prefer using the Mini Mental State Examination, which can be used even in illiterate patients because there is a different cutoff. Usually, we keep the cutoff around 24, but in illiterate people, we do have a version where there are more questions that we ask in order to ensure that they score adequately. Now, there is also a test called the General Practitioner Assessment of Cognition. Now, this is not very commonly used, but again, does not take too much time and can be used in an OPD basis. Coming to locomotor assessment or the physical performance, as I said earlier, we have the chair rise test where you ask the person, first thing to do is make sure that they have adequate mobility to get up from a chair. And then if once they confirm that they'll be able to do it, you time the person, as I said, make them sit on a chair, ask them to cross their hands and keep their arms over their chest. And then you tell them to get up and sit down 5 times without using their hands. And when they start, we also start timing them. And the cutoff is 14 seconds. Anything more than that indicates that the person has poor mobility. Now, if they do have poor mobility, the next step that we do is the short physical performance battery. Now, this is a slightly more in-depth test where we assess their balance, we assess their gait speed, and again, the chair rise test. So whatever time they've taken for the chair rise test comes into the short physical performance battery as well. And if you look into the second box here, the third test here says chair rise test, and we give them a score based on the time they've taken to complete the test. Now, apart from that, for the balance test, we ask the patient to stand for 10 seconds with feet in 3 different positions, which I've shown here on the right, far right. One is to have their feet side by side and see if they're able to stand for 10 seconds without any support. The next is a semi-tandem stand. So in this, we ask the patient to keep one foot a little forward and again stand for 10 seconds without any support. Again, we give them a score if they're able to do it or if they're not able to do it. And the last position we ask them to do this is in the tandem stand. So you can see the footprints here which show the actual position in which the participant has to stand. So it's one leg completely in front of the other and both the feet should be touching. So again, if they're able to hold this position for 10 seconds, we give them 2 points as per this from the box here. The next thing we do is a gait speed. So we ask the patient to walk a distance of 4 meters and we look at the time taken to cover this distance. Again, if the cutoff is 4.82 seconds. So anything less than that would be full points, that is 4 points. And as the time increases, we give them lesser and lesser points. So in the end, when we take the total score, the higher the point means better physical performance. Lesser the total points means that they have impaired performance and we need to start appropriate physiotherapy measures to improve their mobility or any pharmacological therapy if they have any conditions that affect their mobility. Coming to nutritional assessment, as I said, the screening test that we do is we ask them if they've had any unintentional weight loss or if they've had or if they have any decreased appetite. Now, the nutritional assessment form that we use here is the mini nutritional assessment, SF standing for the short form. So this is from Nestle Nutrition Institute. So we have a screening question, which is A, B, C, and D. These look into the, we again give them points. So the first question we ask is if they've had a decline, if their food intake has progressively declined over 3 months. The next thing is the amount of weight loss they've had. Third is their mobility status. That is, if they are bed or chair bound or if they are completely able to move around. The fourth question is if they've suffered any psychological stress or acute illness in the past 3 months. Fifth, whether they've had any neuropsychological problems. And the sixth question that we ask is, or we calculate, is the body mass index. Now, if it's not possible to get the body mass index, then we look at their calf circumference. Now, each of these, as you can see, also have points depending on their responses. And the screening score, the maximum is of 14 points. So if the person scores between 12 and 14, they have normal nutritional status. If they score between 8 and 11, they are at risk for malnutrition. And anything less than 8, that is 7 and below, the person is considered to be malnourished. So we need to take in steps to ensure that their nutritional quality is improved. Coming to the visual testing, what we usually use is the Snellen's test. Now, if the person is illiterate, then we prefer using the E chart, as you can see here. Here, we only ask them to tell us which direction the hands of the E are pointing to, whether it's to the right, to the left, whether it's up or down. Coming to the hearing assessment, as I said earlier, we do have screening audiometry tests, which can be done. These are objective tests. And then we have the OPD screening test that we use, which is the whisper voice test. So how do you do the whisper voice test? Is by standing behind the patient at about 1 arm's distance and a little to the side that we're testing. Then we ask the person or the patient to close the opposite ear, either by pressing over the tragus, that is the ear. We close the ear over here, and then then we whisper from the other side, that is the side that we're testing on, 4 unrelated words. Now, this is spoken as a whisper, and we try to see if the patient is able to make these words out. Now, the same way we test on the opposite side as well. And if the person is able to identify or make out the words, then we say that their hearing is normal. Now, again, one thing that needs to be kept in mind is that the words that we use are common words and words that any layman can understand. So coming to depressive symptoms, again, as I said, the screening is to ask them if they've been feeling low or if they've been feeling depressed over the past 1 or 2 weeks, and whether they've lost interest in doing things that they previously used to enjoy. Coming to the actual assessment of depression, we use something called the Geriatric Depression Scale, that is the GDS. Now, there are multiple versions of these. There is the short version, which comprises of 4 questions. There is a 15-question version, and there's a 30-question version. So here, what I've put here is the 15-question version. So again, one thing that needs to be kept in mind when we do a GDS is that you should have good grasp over the language that you're administering this in, because the responses can vary depending on how you ask the questions. So here in these 5 questions, if the person responds positively for at least 5 questions, then we consider that the person has a possibility of being depressed. So then we're supposed to address the cause or start them on appropriate medications. Now, coming to assessment of social needs or the functional status. Now, two of the things that we commonly use is the CAPS ADL index, which is activities of daily living. Now, the ADLs are activities, as I said, it's activities of daily living. So these are things that you have to do on a daily basis without usually expected to be done independently. So the activities of daily living are bathing, dressing, toileting, transferring, grooming, and feeding. So if any of these are impaired, it shows that the person requires additional help from someone to do these things. And this shows a poorer functional status. The other functional status tool that we use is the Lawton-Brody IADL index, which is instrumental activities of daily living. These are activities that require using an additional instrument. And so if a person is fully capable of doing their ADLs, then we also check if they are capable of doing IADLs. Now, if they have any impairment of IADL, again, it shows that their functional status is not as expected as of a young person, but they need additional help to do some things in their daily life. So coming to the instrumental activities of daily living, we have the following, which is administering their own medications, going out grocery shopping, preparing meals, using a telephone, driving or using any form of public transport, handling own finances, housekeeping, and laundry. So, for somebody with dementia who has a cognitive decline, they may find it difficult to handle their own finances. They may have difficulty in driving or transporting. They may have difficulty in using a telephone. So, now all of this indicates that they will need somebody else, that is either their children or a caretaker, to help them get about their daily life. When it comes to the activities of daily living, for example, if we take somebody who's had a stroke, they may not be able to take a bath by themselves. They may not be able to move around, that is, transfer themselves from one place to another. Feeding may be difficult for them. So, this again indicates that they have higher social needs or they need more help doing about the daily things. Basically, it shows that their functional status is declined and they are functionally dependent on someone else. Now, why the functional status becomes important is that it becomes a major factor when it comes to possible elder abuse, because as the caregiver burden goes up, the frustration that caregivers have also increased and they may take it out on the dependent elderly. So, how to look about that is first observe the behavior of the older person that approaches you, that is a patient. Now, they may be afraid of a relative or a professional caregiver, or they do not want to answer questions when we ask them, or they look anxious around the caregiver. If the caregiver isn't around and has just walked in, they may show a sudden change in their demeanor when the caregiver walks in. And many a times, elderly do try to cover up or justify the behavior by saying, uh, my son is too strong willed or he's too tired from all the requirements that I have. So that kind of shows that they're trying to cover up the ill behavior that they're facing. Another thing is that they may show an exaggerated respect for the caregiver. Again, because they're afraid of being abused because they did not show. Now, other pointers that we look at when it comes to the behavior of the caregiver is whether the caregiver hinders the healthcare professional from speaking to the older person. Usually, this happens in a setting of the hospital where we ask the caregiver to step out for a moment, or when we want to examine the patient, but the caregiver insists on staying there. And sometimes they do not allow us to speak to the elderly on their own. They prefer to answer questions for the elderly. They may introduce obstacles in the way of providing assistance. So, if we say that we have a home care team that will come and help you out, they often say, "Oh no, I'm not home at that time. Can we reschedule for another day?" So, these are ways that they hinder us from providing care. Then they may show a high level of dissatisfaction about having to take care of the older person. So they may say it openly that this has affected my life. I'm not able to go for my job properly, and they may complain about the burden. Now, many a times we do see caregivers who also complain that the person that they are caring for, the elderly person, has psychological issues, and that sometimes they say that the person is crazy. They're making up reasons that they're not actually sick, but they keep insisting that the person is sick. Again, another thing that we see is that some of them have a very hostile approach to us, especially when we ask them any kinds of questions, or they're very restless, or they do not want to answer to us. Again, when we examine, or even when the nurses examine, they may notice any cuts, burns, or bruises, or scratches over the body. We may be able to notice injuries that do not match the explanation that the elderly people give. They may have injuries that do not look accidental. And sometimes we may see injuries in concealed areas, or bruising that may be shaped that may have an impression of the fingers, especially from rough handling. And it can be in protected areas. The injuries may be untreated, or sometimes people may have multiple injuries at different stages of healing, which means that they've been maybe abused multiple times over a period of time. Also, the other way that we see is either medication overuse or underuse. Again, that underuse may point to possible neglect because the family members may not be buying medications as the patient requires. Coming to the second tool that we have is the comprehensive geriatric assessment. So this is more or less similar to the ICOP assessment. Only additional things that are added in the comprehensive geriatric assessment is the assessment of functional status, whether the person has incontinence, whether there is polypharmacy, and whether there is any abuse, not just elder abuse, but also any substance abuse. And the drawback for this one is that it's a questionnaire-based assessment. So patient responses may be unreliable, especially if the person is in denial of their symptoms. For example, due to the associated shame, some patients may not be willing to accept that they have incontinence, or they may be too afraid to accept that they are being abused. And another difference here is the timed up and go test. That is what we use for mobility assessment in a comprehensive geriatric assessment. So this is a picture of the timed up and go test where the healthcare professional mainly makes the person or the patient sit on a chair. We ask them to get up, walk to a point that is 3 meters away, then turn back, come back and sit in the chair. Now we time them for the entire process from the point they get up to the time they take to come back and sit down. Now, again, over here, the cutoff is 12 seconds. Anything more than that indicates that there is a mobility issue. Now, another advantage of this is that we are also able to assess their gait. So, for example, a person with Parkinson's would have a short, shuffling gait. They will have difficulty turning around. So, these also point towards the disease. Coming to the role of nurses in geriatric assessments. The first thing is we require their medical expertise. That is, one is the knowledge of their age-related conditions. The second, we use the help of the nurses in detailed geriatric assessments, that is either in CGA, or sometimes the nurses while observing patients may be able to identify problems in elderly, which could be impaired memory. It could be the interaction that the elderly have with their family members. Usually, the nurses are able to easily pick up signs of abuse or neglect in elderly more easily than a doctor might be able to. Then the nurses are again helpful when it comes to monitoring vital signs, administering medications. They help in managing wounds, and they also perform necessary medical procedures like insertion of a Ryle's tube or a catheterization that they can help with. Also, the nurses, since they're constantly observing patients, especially the IP patients, they are also able to pick up subtle changes that may happen in a patient's condition over the couple of days. The second, the second role that the nurses have in our practice is promoting independence and quality of life. So nurses having constant rapport with the patients are easily able to identify and understand the patient's requirements, and they also realize the need for maintaining the person's dignity as well as autonomy. So this helps us to set goals, especially through the nurses. It helps us to identify and develop a personalized care plan based on the person's goals, which they usually are able to speak about more openly with a nurse, maybe than a doctor. Now, the third one is addressing emotional and social needs. So the nurses are usually, as I said, they're able to identify interactions that the interactions that interactions that a patient may have with their family members or their caretaker. So this helps in identifying conditions like social isolation and loneliness. They again help to identify neglect and abuse. And often the nurses become compassionate listeners in these cases, and they provide emotional support and also help to address the fears and anxiety that a patient may have regarding their upcoming treatment or any procedure that they're due to undergo. When it comes to the next role that the nurses have, they help in family education and counseling. So, one, especially if there are chronic illnesses, the nurses play a key role in educating family members of a patient's condition, as well as the care needs that will arise over time as the condition progresses. They help in counseling family members regarding medication management. They provide counseling regarding dietary requirements, and they also educate the family members or the caretakers about the safety measures that need to be in place. For example, pressure sore prophylaxis, delirium prophylaxis, or aspiration prophylaxis. Even counsel about measures that needs to be taken in a person with impaired mobility to prevent falls, and for a person who's on a catheter or a feeding tube, the kind of care that needs to be provided to maintain the hygiene around the catheter and the feeding tubes, as well as the care that needs to be given to the eyes, oral, back, and genital areas. The next one is that they play an important role in rehabilitative care. So, again, by observing the family and the patient, they help us to set goals of care, and they also help us to aim for the highest possible functional status and promote independence. Sixth is pain management. Again, especially in the inpatient setup, the nurses are able to constantly monitor patients, so they're able to pick up as soon as the person starts complaining of pain. They help us in assessing pain scores, the severity of pain, and how often the pain comes, so that we are able to modify their drugs to ensure maximum comfort for patients. The last one that we'll be talking about is end of life care. So, again, the nurses play an important role in providing compassionate and dignified care to the elderly, and also supporting them and their families, again, through counseling, as well as being a compassionate listener through difficult times as well. Because many times when it comes to terminal illnesses, it is difficult to take a call regarding whether intubation is required, or they want to go ahead with a do not intubate consent or a do not resuscitate consent. So often, more often than not, more than doctors, the nurses are able to provide more support for family members to take such decisions. Thank you.
Dear participant, if you have any doubts, please unmute your mic. Please response. So everyone said thank you. I think thank you so much, ma'am. It was a wonderful session.
Thank you. I've tried to keep it as short as possible because I don't think everything can be covered in a go. But still.
Thank you. Thank you so much.
Thank you, ma'am. Thank you for your insightful session, and I think we can wrap it up for today. So, thank you, ma'am.
Thank you so much.
Dear participants, we have only one more session to go. So, thank you all. So, you can leave now. So, do you have any inquiries regarding the certification? You can reach out me directly, and you can leave now.